talking about the Parkinsonian and movement disorders. Yeah, actually, this is a very special field in neurology field. So I would like to uh, give you a brief introduction and actually some of case I may only seen one or two in my life, and maybe you won't see in your career in your clinical practice. Yeah, but I think for this talk, I would like to give you a concept of what kind of movement disorder and the possible management and drug treatment you can use for that alleviate the symptom and can have a good life quality for them. Yeah. Okay, so this is today's learning objective. We talk about the different kind of movement disorder. We will show you some video differently, and also tell you how to approach the Parkinson disease and movement disorder. And also we talk about a little bit about the management. Yeah, actually, a neurologist we take care about the disease involve the central and peripheral nervous system. Actually, it's from head to toe. Yeah, the most common disease you might hear is stroke, epilepsy, and headache, and the peripheral neuropathy, and some other kind of disease, neurodegenerative disorder you might hear, for example, like Alzheimer's disease, dementia, or Parkinson's disease, and some severe ataxia, motor neuron disorder, and some of these cases might present with movement disorder. The movement disorder, what is the movement disorder? Is happen when an involuntary movement appear or it's worsening when you do the movement. Yeah, so those kind of disease, stroke, multiple sclerosis, neurodegenerative disorder, Parkinson's disease, and cerebral ataxia and some genetic disorder can present the involuntary movement, also the movement disorder. We will introduce to you today. Yeah, the neurological disease disorder burden from the WHO. The first one is stroke. I think everybody knows stroke is can cause severe disability. But sometimes the disease like the Parkinson's disease and the movement disorder can cause some disability. So when we approach a neurological disorder, the important thing is we have to have a detailed history, especially some movement disorder may have genetic causes, so family history is important. And also we have to do the complete physical and neurological examination because some of disease like may have other clinical presentation coexistent with movement disorder. And we do the functional localization because our nervous system is highly organized structure from brain to peripheral nerve. There's a specific organization, specific anatomy, specific neurophysiology. So you can, according to the, the clinical symptom and sign, you can identify the anatomy lesion. For example, like this, the stroke is usually cause the, the brain infarction or hemorrhage that can cause the neurological deficit, hemiplegia or speech problem. Yeah. Or for example, like spinal cord disease, patient might experience paraplegia, weakness of both lower legs, yeah. So this kind of neurological disorder you can have according to knowledge, you can localize where the issue is. So the neurology diagnosis can consist of anatomical diagnosis and the etiology, pathology, and functional diagnosis. So let's take a look at about the control of voluntary movement. Actually, voluntary movement, when you do a movement, do a task, motor task, you have an idea. And this signal will planning by the cortical social area, and this will be fine tuning by the basal ganglia and cerebellum. So the important area may contribute your movement problem is cortical social area, basal ganglia, and also the cerebellum. So now we classify the movement disorder. We can, according to the anatomical structure, it might have different presentation. For example, like Guillain-Barré syndrome, they affect the corticospinal tract. So you can see the typical one is stroke. Stroke, you can see the patient might have spasticity. And for cerebral disorder, the patient might have in coordination or in balance, and cannot do the fine movement. But today I would like to show you some specific, many specific condition affect the basal ganglia. The basal ganglia disorder can cause too less movement or too much movement. For too less movement, is we call it hypokinesia. Means, for example, if we for Parkinson's disease, the one of clinical feature is bradykinesia, slowly on movement. So slowly on movement, we call it hypokinesia. But in some cases, there's a tremor, it's excessive movement. We call it hyperkinesia. We will go through all the condition by video, that you can easily understand what kind of it can belong to each kind of movement disorder. So when we do the clinical approach to movement disorder, the important thing is history. And the many movement disorder, especially those with early onset, maybe childhood onset, uh, those might be genetic causes. So family history is especially important when you see a patient with movement disorder. For example, like with the Huntington disease, Huntington chorea, or spinal cerebral ataxia, you might hear. So those are genetic causes. And also, the movement disorder can be induced by some medication, especially those medication affect the mood. Yeah, antipsychotic, they work on dopamine transmission that can cause the uh, movement disorder as well. So drug history and the family history is important. And also, the movement disorder sometimes they associate some musculoskeletal problem or other neurological symptom or cognitive decline that may be coexist. So you have to have a detailed history and know what the progression. And we need to exclude some acquired condition. For example, if the movement disorder only appear on one side, you should consider the contralateral basal ganglia, contralateral brain lesion may cause this kind of movement disorder. So the assessment we need to investigate, we need sometimes we need the imaging study and the laboratory testing. Some infection or encephalitis can cause movement disorder. And remember, there's some cases may have genetic causes. If we see the similar symptom found in the family, you have to consider this genetic neurological disorders. You have to do testing to find out what the real disease it is. So for the approach of the history, we need to know the time course. It's acute onset. I think acute onset usually maybe you need to find out the trigger. What kind of trigger? Maybe sometimes, for example, like stroke can present the shaking limb syndrome, can have some movement disorder like. Yeah, and we'll have to know the functional disability. Yeah, sometimes the movement disorder only appear in some condition, especially in task-specific dystonia. I'll show you the video later. Yeah, and especially Jackie Chu and Fancy Chu are important. I have mentioned several times. Yeah, so for about the examination, to see is to breathe. So you watch the movement, you can make a phenomenology diagnosis. Then there's a subsequent, you can have a cellular differential diagnosis to find out the real cause of disease. Okay, so let's take a look those specific movement disorder. I'll show you by video one by one. So Parkinsonia is a syndrome patient with breathing kinesia, meaning slow movement, and always accompanied by maybe tremor and increased muscle rigidity. For dyskinesia is can be any kind of involuntary movement. For tremor is a rhythmic, involuntary, oscillatory movement. Uh, Oscillatory is you see the which is a to and fro movement. Yeah. For Korea, it's a quick and semi-purpose and unpredictable movement, unpatterned movement. For dystonia, it can be show abnormal posture. It's because of the sustained muscle contraction. So sometimes you can see the muscle hypertrophy in dystonia cases. Yeah, for myoclonus, it's a brief jerk-like contraction of a group or a specific muscle. I'll show you a video later. And tics also is a jerk-like, non-rhythmic, but it is a stereotypic type of the movement. And sometimes tics can be presented with motor action or with vocal part. We call this Tourette syndrome. And also, stereotypy is a purposeless voluntary movement. You think it seems to do something, but you have to define what it is. So let's start from the Parkinsonian. Parkinsonian, the core feature is there's a four core feature. TRAP, trap. T means tremor, R means rigidity, B, A means breathing kinesia or kinesia, slow movement. P means postural instability. So you can see on this picture, you see there's the typical Parkinsonian tremor is pure rolling tremor, like a counting bill. And sometimes the patient can have the hypomimic faces. Hey, hey, 是，哎，哦，哎，我可以可以去，我现在可以去查。我做一下，打电话通知我。对，好。Okay, so you can see the hypomimic face, the mask face, and the walking is a stupid posture, leaning forward. Yeah, you can see the video. For the left, after you see the tremor, it's risky movement. For this one, there's a slow movement. You can actually do the finger tapping. For rigidity, you can pull the arm and the leg to feel the resistance of the limb on the joint. And for Parkinson's disease or Parkinsonism, in the advanced stage, they may affect the postural reflex. So there's a postural instability. So sometimes even very severe cannot stand by themselves. Yeah, so this is Parkinson's. So what kind of Parkinson's disease? This is a case scenario like this. Uh, uh, is a 56-year-old man. Yeah, had the 5 years ago he has died of the channel right side hand. So for a typical Parkinson's disease, the typical orientation is one side, from one side to bilateral. And the onset age for the Parkinson's disease is around 55, around 55, 50 to 55 years old. So the Parkinson's disease is a neurodegenerative disorder, so it's the progress. So it has increased pattern, so there's some uh, functional impairment, especially to some fine movement, and also there's rigidity, so he cannot swing the arm when he walk. Yeah, so that's a typical presentation of constantly from one side to bilateral, and in the advanced stage might affect the walking pace. So yeah, so this kind of treatment indication. So sometimes uh, we can see the leg like this. Is anybody know the name for the leg like this? This is the medical term. Yeah, the vertical discoloration of both legs. Does anybody knows the specific term? Nobody know. It's called the libido reticularis. Libido reticularis. This can be happen in autonomic dysfunction or in extreme cold circumstances, the peripheral vessel constriction, and also this can be present in some drug treatment, especially in the drug we use for treat the Parkinson's disease, amantadine. It's called the libido retinopathy. You might see the respiratory. Yeah, and also there's a micrographia, the writing is very small. So for Parkinson's disease, is similar to Alzheimer's disease. It's a neurodegenerative disease disorders, and it's age-related. So the prevalence of the, Parkinson's disease is same as Alzheimer's disease. Is get higher and higher following the age. And also you see the site male predominance for Parkinson's disease compared with woman more in, for Alzheimer's disease. Why we call this Parkinson's disease? It is because James Parkinson. James Parkinson is a physician in London. He first described 6 cases presenting with advantage movement and lesser muscle power and limitation of support and the propensity to bend trunk forward. Yeah. So he published this essay on the string palsy on 1870. Uh, Later on, the French uh, neuropathologist and neurologist Charcot, he named this kind of condition as Parkinson's disease. That's why we use Parkinson's disease to name this condition. So if you born 200 years ago, you can have your name on the disease. left side really kind of you see the footstepping is slow, and you see when you walk, the left arm doesn't swing. It's because the bradykinesis and the sound is so. What kind of person might have Parkinson's disease? Anybody know this one? This guy? Yeah, you have a good place from the issue. That's a chicken. You see why he only use his right hand? It's because he has Parkinson's disease. He has left hand tremor and left hand brain kinesia. So it's a historical film. You can see the, the, the disease in the adult people. You know, yesterday I talked this in RFN. Only one man know this guy. I think you are all too young. Don't know didn't know the history about the World War II. Yeah, and also there's a boxer, maybe, and pop and actor, Michael J. Fox. So those are celebrities affected by the Parkinson's disease. So after you see that, you know this Parkinson's disease. So maybe the Hitler got the disease, and so he has a crazy idea. Yeah, so let's make a mistake of World War II. So what is the Parkinson's disease? The Parkinson's disease is two pathological marks. One is the uh, different substantial network dopamine loss. Actually, when we uh, grow, uh, we don't the neuron number get less and less following the age. But not everybody gets Parkinson's disease. Only when you lost at least 50 to 60% of the neurons, you will present those symptoms, tremor, bradykinesia. And the other form of this in body, this is eosinophilic intraneuronal infusion body. So the neuronal loss causes the dopamine deficit, not enough dopamine. So the dopamine can control your movement. So it's lack of dopamine causes the Parkinsonian symptom. So how to treat? Give dopamine, right? It's simple. So this is a facial syndrome. The very important thing is the dopamine pathway. The dopamine pathway is the dopamine neuron is located in the substantia nigra pars complexa. It innervates the striate and then control the subsequent neural pathway through D1 receptor. Dopamine D1 receptor is the pathway to control the movement through the inhibition of the D2 pathway, also modulate the movement. So if it's gone, there's no activation of D1 pathway. So that may cause the hyperactivity of GPI and SNR, then increase the inhibition to thalamus. Finally, the thalamus motor cortex drive is too small, so it causes the bradykinesia. So that's why the Parkinson's disease, one of the core features is bradykinesia. It is because of dopamine neuron loss and the lack of dopamine. So lack of dopamine, just give dopamine, right? But it's not easy. I will tell you the treatment. So now that we diagnose the Parkinson's disease according to the clinical presentation. Uh, for about 30 years before, we, we, we needed to have the postmortem study to confirm it is dopamine neural loss and Lewy body to say it is clinical, it is definite Parkinson's disease. But nowadays we use the clinical criteria to diagnosis the Parkinson's disease. So, so there's a clinical established and clinical tolerable. So it's needed to some supporting criteria to to make sure it is Parkinson's disease rather than other disease presenting like Parkinson's disease. There's several conditions might present like Parkinson's disease. They also can present tremor, rigidity, bradykinesia, postural instability. They are not, we call it typical Parkinson's disease. They are not only the dopamine neuron loss, they have other neuron degeneration affected. So for typical Parkinson's disease, it's better to see this immediate onset, like Adolf Hitler is at one side, and the tremor dominant, and also it's slowly and progressive disorder. And one important thing is because it's a lack of dopamine, so it should be respond to dopaminergic therapy, right? If not, it's not typical Parkinson's disease. Okay, so how about the typical feature? The typical feature is you not respond to dopaminergic therapy, and also have some class syndrome. For example, if you have severe ataxia combined with Parkinsonia, which is maybe due to a motor system atrophy. If you have the vertebral case palsy, it's due to the new brain degeneration. It's called the progressive supranuclear palsy. If you have the cognitive dementia, early dementia, due to the dementia of Lewy body type. So the Lewy body is not only in the substantia nigra, but it's also in cortical neurons. So that is not a typical Parkinson's disease to present. And also some secondary causes, brain tumor, stroke, injury, encephalopathy, hydrocephalus. Those diseases might present very similar to Parkinson's disease, but they are not Parkinson's disease. Around 70% are typical Parkinson's disease. Why do we need to differentiate typical one? Why? It is because if a patient is typical Parkinson's disease, the disease course is slowly progress, is long. So Parkinson's disease, I have a patient, he has Parkinson's disease about 30 years. So the disease is not as we think, develop very soon. But for a typical Parkinsonia, for example, like multiple system atrophy, the median average survival is around 8 years. So for the most typical Parkinsonian, they have faster progression and the poor response to the domination. So this is a criteria. If the patient has some atypical sign, we have to consider atypical Parkinsonian. So it is a red flag sign. If the patient has progression too rapid, this may be not a typical Parkinson's disease. Besides the clinical symptom, we also can use some neural image to identify the possibility of is a typical one or atypical one. This is an image called the dopamine transporter image. This is widely used in many countries, including Taiwan. But I think here we don't have these resources. This image user light and can bind into the dopamine transporter. Dopamine transporter is only expressed in the dopaminergic terminal in the striatum. So it's a good indicator to know how much, how many dopamine neurons left, still left in your brain. So you see, for in normal one, you see the bilateral is very high uptake. But for Parkinson's disease, you see one side is decreased. So it's a great image visualization. You can see, oh yeah, it's a one side dopamine deficit. Yeah. And other image modality can present, for example, like if you see the cerebral atrophy and there's pounding brainstem atrophy, so you see that there's a cross. Have you had like this cross bump? Yeah, you know that. Yeah. So yeah, this is actually this is my first time really see this kind of cross bump in the flight on the flight to Eswatini. Yeah. So if you see the abnormal atrophy in cerebellum, it's not Parkinson's disease. It's another disease, multiple sclerosis, and those diseases will progress faster and not respond to dopamine therapy. So the progression, but however, the Parkinson's disease, neurodegenerative disease, still can have a slow progression. So we define the different stage of Parkinson's disease according to the functional disability. So for stage one is unilateral symptom, like you see the video, Hello Peter is and one side doesn't move and tremor. For stage two is bilateral involvement. For stage three, there's some gait problem, but you can walk independently. For stage four, you need assistance for walking. For stage five, confined to wheelchair. Most patients from stage 1 to 2 takes about 1 to 2 years to evolve from stage 1 to 2. But most patients stay on the stage 3 for 10 or 20 years if the good care and the good response to medication. So they can stay on stage 3 for 20 years. What is the cause of Parkinson's disease? There's several molecular mechanisms involved, and genetic factors should be contribute in some because about around 10% of Parkinson's disease they are familial cases. 90% cases are sporadic, but not the 10% they are genetic, will be genetically related. And uh, recent 20 years from 1997 is found there's the first uh, gene related to Parkinson's disease has been identified as alpha-synuclein mutation. So I also do the neurodegenerative study for Parkinson's disease for many years. So around one third of patients which onset, this is on age of onset below 40 years, they we can find out the genetic problem in those cases. So young onset cases, genetic factor is important. But for late onset, that might have several kind of factor, environmental factor, and for example, like pesticide use, some toxin, yeah, and the aging that can contribute. Yeah. About the treatment, I would like to introduce, if you have time, you can take a look at this cinema. It's called Awakening. Anybody have seen this cinema? It is cinema is 1990. So maybe you are now still not born. Yeah. But this story is talking about a disease called encephalitis lethargica. It is endemic around 1930. 1930. So there's several cases they survived and became mute and cannot move. So the doctor uh, finally find out the good medicine can let those patients become active again. So that's why look like the patient sleeping and then wake up. So this I think is a very good uh, cinema based on the true stories. Very kind of, yeah. So what kind of drug he used is levodopa. Actually, from 1917 to 1960, there's no good medication for Parkinson's disease. So, but there's Bobby Carson. He found that dopamine is important neurotransmitter in basal ganglia. And lack of dopamine is the cause of Parkinson's disease. So this important finding direct treatment development for the Parkinson's disease. So nowadays we can see the Parkinson's disease they can survive more than 30 years. So it's because we have good medication they use. Yeah. The other guy, he is got chemistry, Nobel Prize in chemistry, because he can uh, efficiently convert the to the L form. Why don't we use dopamine for treating Parkinson? Why don't we use dopamine? Are you using dopamine in the world? What purpose you use dopamine in the world of casualty? Dopamine. What purpose do you use in the world or in the casualty? Elevated blood pressure. For the low blood pressure shock condition, you use dopamine, right? Yeah, but dopamine itself cannot penetrate cross the blood-brain barrier. Yeah, it's because it's a polar structure, so it cannot penetrate to the brain. So that's why we need a prodrug. It's called the levodopa. So levodopa can uh, penetrate through the blood-brain barrier to the neuron. Then in the neuron, it can be converted by the enzyme to become dopamine. So that's why we use levodopa, not to use dopamine to treat Parkinson's disease. So nowadays, the medical treatment for Parkinson's disease we center on the replace the enough dopamine. So we use levodopa preparation and use the medication to act on the post-synaptic dopamine receptor. And also we use some medication, for example, like Tu-Hsueh Yeh and OP. Those drugs will delay the metabolism of dopamine in the synapse, so it can prolong the effect of dopamine in the long term. So that's why we nowadays we use medication to treat the Parkinson's disease. However, the Parkinson's disease is neurodegenerative disease. It still can be get worse and worse. And also, when the aging process, there's other system maybe other neuron may be dying at the same time. So in the advanced stage Parkinson's disease, they may have some non-motor feature like pain or immune symptom or also say hypertension and also can have dementia. So that's the problem when we treat Parkinson's disease. If they initial a good treatment for 10 or 20 years, we might face with a non-motor limitation. And also the levodopa can induce, like this is a levodopa induced dyskinesia. So when the aging process get worse and worse, the therapeutic windows can narrowing. So if you give one dose of levodopa, if the level go too high, it will cause dyskinesia. So if it drop too low, the patient cannot move because of dyskinesia. So the patient in the advanced stage Parkinson's disease, they may experience the wearing of arm of phenomenon and the level of dyskinesia like this kind of cases. So there's another some of patient might for treatment of dopamine difference dementia. We put a small, very small electrode into the substantia, into the subsami nucleus. That can you see the patient before the surgery, he cannot move very well, and even cannot move a chair at home. But after the surgery, he can walk and can walk as before. So that is a technical advance to treat the Parkinson's disease from the 1990, almost 30 years. So let's take another movement is tremor. Let's take the video. The tremor is a rhythmic movement, it's an oscillator movement, like a vibrator movement. But it can be very worse to affect the daily activity. For example, like you say, you even cannot hold the cup to drink, so that may cause very severe functional disability. And sometimes you see there's only one side tremor, and you can count the frequency, and it's also presenting restless. So this is one side is the Parkinsonian tremor, and the right side. Let's take a look. This is also a tremor, but you see the tremors happen when it's close to the topic, so we call it intention tremor. The intention tremor is neuroanatomy causes is cerebellum, not basal ganglia, not the lung nerve. So we classify the tremors according to when it occurs. So the tremor can occur at rest, like for example, like Parkinson's disease. You just put your hand, put the hand down, you see the tremor. Or it can happen only when people are prostrate. Yeah. Actually, for young men or young women, the postural tremor, the most common cause of postural tremor is physiological tremor or hyperthyroidism. So if a young lady comes to see you, oh, I have a tremor. Oh, tremor like this. Check the thyroid. Check the thyroid. And also, the kinetic tremor can be related to different kind of case. If it's only happen when reach to the topic, should we consider attention tremor because of ataxia. So it's a different kind of So for the medical treatment of tremor, we can use beta blocker if not contraindicated. What kind of patient we cannot use propranolol? Asthma, right? Asthma. The patient with asthma, we don't use the beta blocker because it can worsen the asthma. So, and also we can try benzodiazepine because some tremor they will aggravate by the anxiety, so you can give some benzodiazepine. And also for essential tremor, we can use primidone. But primidone is a very severe adverse effect to sedation. So it's not sometimes it's not good for treatment for a patient because it's severe. And other anti-AD drug can be used, topiramate, topiramate, carbapenem might be effective. And also for the case you see the first lady is shaking very severe, we can do the surgical treatment to targeting the sounds. Yeah. So let's move on to the third one, dystonia. The dystonia, the definition is abnormal movement, sustained muscle contraction, can cause twisting or repeated movement or abnormal posture. So like this abnormal posture. It's affect the generalized body, so it's a generalized dystonia. For generalized dystonia, it's usually start from the very young age, child onset. Or it can also happen in the focal one. For example, like this older lady, we call it the facial spasm and facial dystonia. It can also affect only the neck. You see the cervical dystonia. And also, sometimes the dystonia only happen when doing some tests. For example, like when you're writing too many words, it can abnormal contraction of your muscle. So this is text-specific dystonia. So text-specific dystonia often happen in the skill chain movement, like writing or like doing some fine work, like doing play the piano, play the guitar. You see? You see, when you play the piano, the index finger cannot flex as smooth. So for like this guy, play the guitar, when he play guitar, the index finger is going flexion. So for treatment, this kind of specific focal dystonia, the best treatment is botulinum toxin injection. Botulinum toxin injection. We have to identify which muscle has abnormal contraction, then inject botulinum toxin to paralyze it to treat this kind of condition. You see the abnormal posture on the left hand. Yeah, for this case, uh, it's very young, says 23-year-old male. There's a different kind of, besides this dystonia of the left hand, he also has slow speech, unsteady gait, and other involvement. And for this kind of young onset movement disorder, we need to check cerebral palsy because it is a triple condition. The Wilson disease is a, a coupled metabolic problem caused by ATP70 mutation. It's an autosomal recessive condition. and it can affect the liver and affect the brain. It's because of the excessive copper deposition there. So the patient may have liver bronchitis, liver failure, or that movement disorder, or psychiatry like this patient. And also there's a characteristic findings. The abnormal copper also can deposit in the cornea. So you can see the paper pressure inside the cornea. There's a brownish. Yeah. But also the image, right? You can see the long uh, 5 meter deterioration. So you see, this is a big red, very similar to Panda. You see the ear, black ear, and a black eye. Yeah, yeah, very similar to the panda. Yeah, it's very it's finding of this. So for a young person presenting with long movement, you have to check the cerebral plasticity and the liver function. It's it's a treatable disease because this kind of disease we can use chelating agent and reduce the copper in diet can be controlled with the medication. So this in Taiwan we have specific genetic causes in the exon 8 with a mutation hotspot. It's a previous study for 83 version mutation, and the seroplasmin is less than 12. So, according to the American Association of the Study of Liver Disease, the recommendation for unknown liver problem, you need to check several pathways to see if it is worsen disease. Okay. So for this case, you see the 5 a.m. This lady, you see the movement is a little bit slow, right? So we can say it has bradykinesia, so it's some Parkinsonism feature. And also you see the foot tapping slow, right? And then there is a abnormal posture. You see the foot is inverted, so it's abnormal posture. So the patient has dystonia, and also the slow movement she has Parkinsonism. So it's complex. Complex. She has Parkinsonian and dystonia as well. So sometimes not only one kind of. So you see the 7 p.m. It's became worse. So now she has neck dystonia, femoral dystonia, severe foot dystonia in the evening. After treatment, look, like a normal, like you and me. Did you see any abnormal? No, it's very, very dramatic, right? Yeah. This patient has a gait problem, inversion of foot since the age of 9. So for the very early onset of movement disorder, you have to consider its genetic causes. And we trace back the family trees like this. One, two, three generations all have such kind of presentation. So this is what kind of inheritance? Autosomal dominant inheritance. Yeah. This case is what kind of drug can can give the patient so dramatic response? What kind of magic drug, magic pill? Anybody want to guess what medication? It's basically a disorder. So we give what? Give dopamine. We give a very good response to those dopamine. Why? Why the patient responds so good to levodopa? This is because this is disease we call it Segawa disease, DYP5. This is because the GTP cyclohydrolase 1 gene mutation, so cause the enzyme activity uh, getting deficient. So in turn, it affects the enzyme activity of the tyrosine hydroxylase to convert tyrosine to dopa. So we supply the levodopa here can bypass this pathway tyrosine to dopa. So that patient we just give the very dose, very low dose levodopa, she can have dramatic response. So we also call this dopa response dystonia. And for this case, we also see there's a time difference. So in the early, the patient has some problem, but not severe. But to the end of the day, it became very severe. So it had diurnal change of the symptom. Not many diseases have diurnal change of symptom. This is one of the example. The other example we can say, the myasthenia gravis. Yeah, myasthenia gravis can be good in the morning but wake up, but get worse in the afternoon. I think you don't have myasthenia gravis. You very good, very clear. Okay. So not many disease has diagnosed change. So this case, when she start working, yeah, it's a normal posture, a more professional that even she cannot stand and walk. But after several seconds, she's okay, she's fine. So it's only happened when she start working or start doing work. And also it's age onset 10 years, so very early. So we need to think that this is genetic causes. So according to the phenomenon, it's a paroxysmal attack because it's a very short time, and it's triggered by movement. So we say it's kinetic. Kinetic. Kinesia means movement. So kinetic, and it's very short, very quick. So it will say paroxysmal. So paroxysmal kinetic dyskinesia or paroxysmal kinetic dystonia. So this kind of condition usually have very early age onset, around 10 years. Yeah, and the trigger is sudden movement, standing up, start walking, and usually the brain injury is normal. But it has a very good response to carbazepine or other NMP. And about one and a half of the cases, uh, they are familiar cases and carry the PRT2 mutation. So this case also clear the PRT2 mutation with the C49 duplicate. The mutation hotspot. So how do we treat the dystonia? Actually, dystonia is sometimes very difficult to treat. Yeah, it's need a personalized to treatment. For example, like task-specific dystonia. The dystonia only happen when play guitar, play piano, or writing. So we need individualized. And for oral medication, we can give anticholinergic. And remember, you can try levodopa because some cases they are dopa responsive dystonia. You can try levodopa. And there's other medication, dopamine might be helpful, but not cannot cure. And botulinum neurotoxin injection is especially uh, effective for the focal dystonia, especially if only one muscle or two muscle of normal contraction, you just paralyze them, and case the patient has good functioning. Uh, so for the generalized dystonia, some patients might be benefit for deeper stimulation to the GPI. Let's move on to the other one, Korea. Korea is a hyperkinetic movement disorder. There's some character including involuntary, is random, non-pattern. So it's actually the Korea is from the Greek term dense, dense, dense. So this is like a street dance, anybody movement. Yeah. So another characteristic finding is motor inconsistence. It means the patient cannot keep a posture, keep an effect for too long time. So there's like a milk maiden breathe. So normally you ask a patient to breathe, they can do it firmly. But for the Korea patient, it's will like milking from the cow, so it's milk maiden breathe. And also this can affect the tongue. So if you ask the patient to protrude the tongue, cannot persist, and also you can see the tongue to and fro movement. And especially for young children, if you see the chorea of normal movement like this, you have to consider one important disease, group A beta hemolytic streptococcus infection. This post-infectious disease caused autoimmunity. It can affect the brain because of sedent chorea, and also it can cause heart problem, rheumatic heart. So if the patient has this kind of, you have to notice, check the heart. And this is Huntington chorea. I think uh, many of you should hear about this disease. This is also a genetic disease. So this another guy, another physician called George Huntington. So you see, if you were born 200 years ago, you can have your name on the disease. Yeah, George Huntington. Yeah, he first described some family presented like this. So Huntington disease, Huntington chorea is triad, autosomal dominant, and they have movement disorder chorea at this patient, and also has early dementia. So when we see a patient with movement disorder, we have to look at other non-movement disorder problem, for example, like cognitive or psychiatry feature. And the interesting thing is the Huntington chorea is also more dominant. The genetic cause is because there's abnormal expansion of childhood repeats. Uh, so if the repeats greater than 40, the patient will have the symptom. But if the patient, if the one the repeat between the 36 to 40, it may not have disease or have very late onset. But the interesting thing is uh, when the patient has the borderline CAG repeats, the next generation may may get much more CAG repeats. So we call it anticipation for the generation by generation disease onset will be earlier and the repeat number will get longer. So this is very interesting genetic finding. And also, for the image finding and pathology finding, we see how they atrophy. So this is another person present like the hormone involvement movement. There is another, yeah, especially the tongue. He has tongue biting and you see the tongue movement is not smooth. So this is another type of chorea patient with later onset. Uh, so this case has some specific features. He has increased elevated CPK and the blood smear is there's erythrocyte RBC. This is a cancer is different, not like this. So the erythrocyte. So it's called the neuroerythrocytosis. It is because of the S-link problem mutation by in the SKG. So this is case we have one family report in 2014. And sometimes you can see such kind of movement disorder in the emergency department or in the internal medicine world. You see it's only one side involuntary movement, one side we call it hemichorea. So for one side, involuntary movement, we have to think about contralateral basal problem. So actually, we can see the contralateral MRI, you can see this T1 waving high signal intensity. Those kind of conditions usually happen when the patient sudden onset and poor control diabetes. Yeah. Today, my clinic just had this kind of patient come to see me. Her HbA1c is 13%, 13%. It's poor control diabetes. So diabetes and control is very important, not only for the kidney, vascular, and certain poor control diabetes can present with involuntary movement. So the treatment for chorea, we can use the pharmacology therapy with synaptic inhibitor, like pregabalin, or sometimes we can use haloperidol from BP blocker. So for the patient I have seen this morning, I gave her haloperidol to, and his her chorea get alleviated. But also there's some underlying cause we need to clarify and treat. For example, the patient I have seen this morning, I educate for the sugar control. The next is myoclonus. Myoclonus is a brief involuntary twitch of muscle or a group of muscle. So it can be a sudden muscle contraction, we call it passing myoclonus, or brief lapse of contraction. So lack of contraction, like this, when you ask the patient to raise up, with sudden loss of muscle tone. This case, you might see in the internal medicine world. Yeah, for example, like the renal carbon or Chipati and Savalopathy, you can see like this. We also call it, maybe also call it hysteresis. So this kind of condition you can see in internal medicine world. So next time you can say, oh, it's a active marathon. Yeah, very professional. Not just describe, oh, it's a involuntary movement. But what kind of involuntary movement? You can have a specific. professional term, right? And the mindfulness, we know it is abnormal muscle contraction. So it may be generated by cortical neuron or by subcortical, structural, or brainstem, or spinal cord, or even the peripheral nerve can cause the the muscle contraction. So this is an example we see uh, drug-induced mindfulness. This can be seen in elderly treated with some medication. For example, this case treated with memantine. But in Taiwan, I think I saw many cases, maybe the elderly patient they treat with the antihistamine, just treat for the common cold and get a shaking of the body. Yeah, but it's usually self-limited. You just give, start the bending job and give, you can give the benzodiazepine. The clonazepam is especially effective for those kind of mindfulness. So check history taking is important, especially family history and job history. So this another case. This also very early onset. So it's also a genetic causes. So you see the jerking movement. The next call is tactile sensitive mindfulness. So this case is lysosome storage disorder. One of my patients for the cyanosis type 1. This can also present with mindfulness ataxia, seizure, and also the fungus sigma spark. There's a genetic causes. There's a mutation hotspot in Taiwan. The mutation can cause the enzyme reduction about 1 to 10%. So there's several lysosomal storage disease. Yeah, we will have time we can talk some of them later. Yeah, sometimes the mindfulness is stimulus sensitive and can be spread from one body part to the other. You see, you found this part spread to the neck. So this is an interesting character for this kind of mindfulness. And we also can see it's just just like small field concentration. So it's mini polymyalgia. And you also see the muscle atrophy in the young man. So this is a condition we call Rama disease. It's a focal motor neuron degeneration. So peripheral nerve problem can also cause the mindfulness like this. So for treatment, levetiracetam, valproate, clonazepam, you always can try. Yeah, if you feel the patient have enough, you can try those things. Tics, common motor tics can be simple, like typing, jerking, shoulder shrugging, or can be complex, repeating movement, gesturing, stacking, or sometimes it can have vocal component. So if you have the vocal component combined with motor tics, we call it Tourette syndrome. Tourette syndrome. So that is I think the light is too light, so you can it's the head shape movement. So this is spinal ataxia. Also can prevent the slowly of movement. And you see the dysmetria of the hands. So it can prevent complex beside the ataxia, you can prevent some Parkinsonism and slowly or time. This SCA2 is also a disease caused by noise tension or tremor diabetes. similar to the Huntington. You see the white cascade. Uh, and sometimes you can see not like this. Maybe you can see in stroke patient, you can see the one side doesn't move very well, and stiff or muscle, and increased muscle tone, and spasticity. The diffuse spasticity coverage nowadays about 70, very many cases. This case is not diffuse spastic coverage. I want to show you how to examine the increased muscle tone. Yeah, for increased muscle tone, you can do the PPR, and you can also do the ankle tonus. Yeah, how to reduce ankle tone, just like the patient to fast and move. Yeah, if there's more than 4 jerk, so it's ankle tonus passive. It's because of the spinal tract problem. So this case is genetic disease, SE, we call it SE. So this also has environmental issue. This disease, there's also another cinema talking about this disease. This is also based by a true story called Lorenzo story. Lorenzo story. Yeah. The parents of the patient, they finally find a way to treat the disease. Yeah. The disease is because the very long-term fatty acid metabolic problem. So there's accumulation of very long-term fatty acid in the nerve cell and bodies. So it's caused a nerve dysfunction, nerve inflammation. So for one of treatments to reduce the intake of very long-term fatty acid. So the parents find out a good recipe to make a little change of fatty acid to avoid the accumulation of very long-term fatty acid. Yeah, let's move on to the next one. One of my patient has early onset of some disease at age 55. So sometimes you see, there's one day patient comes and his wife talking about at home he do like this movement almost every day and frequently when he gets a pepper, he like to do that, do a very continuous, yeah, similar movement. So it's look like purposeless movement, but it's a stereotype because it's stereotypical. It can occur in especially in the dementia patient. What kind of job, previous career for this patient? You guess what kind of you guess this actually this movement might related to his previous career. What kind of huh? Saxophone? Not no. Anyone want to guess what kind of career or what kind of job the patient previous job previous job? You guess? Huh? Magician. Ah, you are far away. Yesterday, in RFN, they say it's accountant, counting the bill. but no. Yeah, actually, this patient is he is a surgeon. Yeah, before he was diagnosed as Alzheimer's disease. Yeah, general surgeon. So I think this maybe he is familiar things when he do surgery. So it's manipulate the organs. I don't know. Maybe sometimes it look like purposes maybe have some meaning to the patient. Okay, let's take a look at this lady. What kind of movement disorder you think? Tremor? Yeah, you can say it's tremor. But it is true tremor. Is it true tremor? What difference between you see the tremor in the previous video? You see the tremor, the frequency is change. Yeah, and do the other one. And it's look like bizarre. Yeah, the inconsistent. And for the right side, what kind of movement disorder you can describe? Huh? Mindfulness, right? Oh, it's like mindfulness. It's just, but it's also not consistent. It's inconsistent. So those two are functional, or we call previously we call it psychogenic movement disorder. Yeah. So now you can tell what is true, what is psychogenic, right? You can describe the phenomenology. So the next slide we give you some diagnostic tool for Parkinsonism disorder in this slide. If the tremor, actually for the essential tremor or like the hypothyroidism related tremor, it usually occur very early, uh, between the 20, 30 years. But if the tremor onset after 50 years, that may not be a essential tremor. It may be due to maybe a tremor dominant Parkinson's or like tremor dominant PD or dystonic tremor. And if there's some problem when you do do buttons or do fine movement or slow movement, you have to think it's not essentially it's Parkinson's disease. And if the patient also has some autonomic feature, like libido irregularis, cold dusty, and sleep autonomic problem, that is not typical PDC. Maybe due to the motor atrophy. Or if a patient has nuclear gate palsy, they need progressive supranuclear palsy. If a patient also has personality disorder, dysphagia, involuntary movement that led into early cancer, you have to check the liver function and the cerebral palsy because this might be Wilson disease. It can be treated by using chelating agent, penicillin or trimethoprim. If a patient has chorea, early dementia, or some dominant inheritance within Huntington's disease. If a patient has diurnal fluctuation of dystonia, you think Sagawa disease. And what medication is very effective? Levodopa. Yeah, yeah, you know that. And sometimes it's a sudden brief onset of patient because sometimes it is. And for Tourette syndrome, they usually the most more prevalent in male and can have early onset more than overdose. And for the case, I think the general condition has spasticity and it's X-linked, so it's male, only occur in male, and have 5-meter lesion. And the last one, if the movement is inconsistent, you think it's not true. It's psychogenic movement disorder. Okay, so remember detailed history. including family history and package. That would be helpful for your diagnosis. And also, notice is there red flag sign. It's a typical feature. But, yeah. For example, like a psychogenic. You think it's like real? Not real. Okay, so any question?